today is a physician, an internist from northeastern Pennsylvania, not terribly far away, Halstead. Practices there in a rural medicine practice with home visits as well as office practice and hospital practice too, or not at this point, and some hospital practice. But also has done a tremendous amount of writing, teaches with Temple University School of Medicine, and has done a lot of speaking as well. And he agreed to come and talk to us about medicine from the heart. Dr. Leo Remakus.
Thank you very much. Very happy to be here with you this afternoon. One of my favorite patients lived in a monastery quite a few years until he decided to leave to pursue other interests. You might have seen this monastery. It's on the banks of the Hudson River, beautiful hillside overlooking Poughkeepsie, New York. And it's at this monastery that monks of all ages work together in complete silence, growing and harvesting grapes and other fruits, which they later turn into wines and jellies. And on his first day in the monastery, my patient was told that he would have the opportunity to meet with a spiritual advisor once every 10 years. And during that interview, he'd have the opportunity to speak 2 words. So he went through the first decade of complete silence and finally had the opportunity to meet with the spiritual advisor and say his first words in 10 years. Cold food. Another decade passed, and once again he met with his advisor and said, hard beds. And finally, after another 10 years, he met with his advisor and said, I quit. At which point his advisor said, well, that doesn't surprise me. After all, ever since you got here, you've done nothing but complain. Just as the patient went ahead and complained about the cold food and hard beds in the monastery, most Americans can usually be found complaining about many different things. And today, the high on the list of current things that Americans are complaining about is health care. In the United States today, we have the most advanced medical technology and most highly trained medical professionals in the history of the world. And yet, with each passing day, greater numbers of Americans cannot obtain health care. With each passing day, greater numbers of Americans lose their health insurance. With each passing day, greater numbers of Americans who even have health insurance are finding out that their benefits are decreasing while their premiums, co-payments, and deductibles continue to rise. And to add insult to injury, many Americans find it very difficult, if not impossible, paying for prescription drugs. In fact, even those that have prescription drug plans have a difficult time meeting the co-payments and deductibles that frequently are attached to such plans. So Americans have a lot to complain about when it comes to health care. But don't get the wrong idea. Not everybody in America is complaining. Included on the list of those who are not complaining are the managed care CEOs, many of whom are paid in excess of $6 million a year in salary, bonuses, and stock options. The drug manufacturers who continue to record record profits quarter after quarter, year after year. The malpractice lawyers whose offices are packed with angry patients complaining to have been injured by overworked or burnt-out physicians. And the legislators who continue to derive most of their political and financial support from big business, especially the insurance industry. Now, many Americans have gone ahead and tried to contact their congressman to complain about health care in America, only to discover the futility of going ahead and complaining to the wrong people. What they fail to realize is that it is their congressmen who created laws that have allowed the formation of our current healthcare delivery system. For example, in the early 1970s, Congress of the United States passed the Health Maintenance Organization Act of 1973, which gave an enormous number of tax advantages to HMOs. Now, there are people in this room who weren't even born in 1973. And speaking on behalf of all of us who were around in 1973, I guarantee you, not many people ever heard of anything called an HMO or a health maintenance organization or managed care. In fact, 2 decades later, Americans in a lot of the parts of this country were just hearing those terms for the first time. And yet in 1973, Congress was already enacting legislation to protect this thing called an HMO. A couple years after that, Congress passed the McCarran-Ferguson Act, which exempted managed care from a number of very important antitrust laws. And a couple years after that, they passed ERISA, the Employee Retirement Income Security Act, which prohibits people from suing HMOs for medical malpractice. Now, to understand each of these pieces of legislation, you have to view it in the proper historical perspective. So, in 1946, a few years after World War II, there were 2 congressmen by the name of Lister Hill from Alabama and Harold Burton from Ohio. And what these guys did was they did an in-depth healthcare analysis of America's 3,076 counties. And what resulted was the Hospital Survey and Construction Act, or what we know as the Hill-Burton Act, which mandated the creation and maintenance of 5 hospital beds for every 1,000 Americans, and also mandated that these beds be made available regardless of a patient's race, color, creed, or ability to pay. Now, with Hill-Burton in the back of your mind, consider the enormous impact that managed care has had on our hospitals in America. With the tremendous shift in emphasis from inpatient care to outpatient care, managed care has forced all hospitals to significantly downsize and downskill. In fact, just a few years after HMOs became operative in the United States only had 3.5 beds per 1,000 people, down from the Hill-Burton mandate of 5 beds. And it's been postulated that within the next few years, it's finally going to continue to drop down to about 1.5 beds per 1,000. Now, if you look at all this, you can say to yourself, well, isn't that amazing? For all these years, Congresses have been passing these laws that nobody seemed to understand, and yet all these laws put together created an entity which has changed the entire landscape of healthcare in America today. So it's obvious that Congress has been writing all kinds of laws about managed care, but Congress nor the state legislatures have done very much in the form of meaningful legislation concerning malpractice. As a result, patients are still allowed to file frivolous lawsuits against doctors. The health insurance companies that provide malpractice or professional liability insurance are still allowed to excessively raise the premiums on physicians, even those with clean malpractice records. And malpractice lawyers are still allowed to hold back in excess of 2/3 of every malpractice award to cover their fees and expenses. So if you look at all this stuff, you got to say to yourself, hey, you know, there's been some people who've been really profiting and benefiting from our current healthcare delivery system. Unfortunately, it's not the healthcare providers and it's not patients. And make no bones about it, no healthcare provider has ever benefited from watching their office, clinic, or hospital turned into an assembly line. And no patient has ever benefited from having their role in this current healthcare delivery system reduced to that of one of a starting point in some algorithm, a variable in some protocol, or a statistic in some evidence-based medicine experiment. But you know, they have an old saying that goes, if it ain't broke, don't fix it. Well, I'm here to tell you, our healthcare system is broke. You have greater than 1 in 4 Americans who have no health insurance. You have equal or greater numbers that have an inadequate health insurance. You get people who can't afford drugs. In fact, they're going to Canada and Mexico on the internet to find their drugs. You have healthcare providers exiting medicine in droves because of the current intolerable working conditions and the threat of malpractice. And yet through all this, you still have people that are making more money than they'll ever be able to spend in a whole bunch of lifetimes. But you know, there's another old saying that says, what goes around comes around. And I am the bearer of good cheer and good tidings and good news and all other kind of stuff, because in America today, as we speak, there are plans to go ahead and actually hand us an entirely different type of healthcare delivery system really in the not too distant future. Now to understand this, I got to tell you a little bit about Dr. Paul Elwood. I don't know if you're familiar with him or not, but he was a pediatric neurologist who in 1969 got so fed up with healthcare and what the government was doing to it, especially Medicare, that he sat down with a bunch of people and they devised a thing which he named the Health Maintenance Organization. And you know, what he put down on paper, what he planned, is nothing like what we have today. In fact, he's come out in many public speeches and said, it didn't have to be like this. He had no clue that big business was going to take this over and create what he calls a cash cow, in which everybody seems to profit except the people who should be, the healthcare providers and the patients. And so he's come out and he's been very vocal lately, and in fact he's even come out and said that he predicts the demise of our current managed care system in America in a very short time. And you know, his comments notwithstanding, there has been ample research done that has clearly demonstrated that managed care is not working in the United States today, especially for our geriatric population. In an article printed in the New England Journal of Medicine by Dr. Robert Morgan and his associates, they analyzed over 450,000 Medicare patients who were placed in Medicare HMOs in Florida. Simple conclusion, didn't save money. Another study that was published in the October 2nd, 1996 edition of JAMA by Dr. John Ware and his associates did a 4-year study on 2,235 patients in Boston, Chicago, and Los Angeles. And what was unique about these patients is that they either had chronic illnesses, they were elderly, or they were disabled. And they were all in traditional health care, pulled out of traditional health care, shoved in Medicare HMOs. And after 4 years, it was the conclusion of the study that 2 out of 3 patients suffered perceptible and measurable declines in their health by being put in that type of system. So we have a system that doesn't work financially, and as they said in the Ware article, could be actually injurious to your health. Now, intuitively, if you think about managed care, it's never been the right system for America because it was based on a military model, a model where health care was provided to small numbers of people who were in very good health, only on an episodic basis, not large numbers of people with chronic illnesses who would require ongoing care. And that's exactly where we're at today in the United States. We have a situation where we're about to embark on twice as many senior citizens as teenagers. So the healthcare needs of America are only going to increase, they're not going to decrease. So as we approach what it seems inevitable, this new type of healthcare delivery system, before we as a profession take this one giant step in the direction of that new system, we have to think about taking 2 steps back and revisiting in an earlier time in American history when the doctor-patient relationship was considered a sacred institution, when health care was the name of a profession, not an industry, where the newest technological advances were no substitute for personal and compassionate care, and where healthcare providers, regardless of their shortcomings or limitations, were thought to be the greatest of all time, the greatest of all ages, because the one thing that they all knew how to do was practice medicine from the heart. Now, if we can go back to that time, if we can rededicate ourselves to those values and principles that brought us into healthcare in the first place, and if we can master the technique of injecting just a few cc's of humanity into our work, then we're going to create a healthcare delivery system that takes care of 100% of Americans, that is user-friendly for all healthcare professionals, and that will long endure. Now, I'm not here today to evangelize, to preach, to convert, and I really can't teach anybody how to practice medicine from the heart. That's something, the only person that can really do that is yourself. because you got to look in your own heart, and you have to find out what's there, and you have to find out how much of yourself you have to give to your profession. But what I can do is I can share with you a philosophy of healthcare that's evolved over the past quarter century, that has employed humanitarian principles, and that has been based on the premise that no institution is more important than a single person requiring medical care. So, to move onward and upward to this whole thing about practicing medicine from the heart, the first thing we got to do is to see how in everyday life there's a transition which one day makes somebody realize, you know, this is the right thing to do. And to do that, I'm going to bring somebody up to the stage. Let me tell you a little bit about her. She graduated from Seton Hall University with honors after only 3.5 years. She excelled academically as well as on the softball field. She was a star on the Division I softball team at Seton Hall. She's the only woman in the history of Seton Hall University to have been named president of the prestigious Varsity Letterman's Club for 2 years. And some of her honors at Seton Hall included being named an academic All-American, a Big East Scholar Athlete, and being named one of Seton Hall's top 25 women. On paper, her name is Alexandra Remakus, but to a very proud father, she's the medicine that keeps my heart going, my daughter, Allie.
I'm about to read one of the writings from Dr. Remakus' book, Medicine from the Heart, and it's entitled My Travels with Ray. I had just finished admitting Ray to the hospital when my office phone rang. "Can you tell me why this patient requires hospitalization?" the young woman asked, identifying herself as a representative of a major health insurer. "Ray's no longer covered by your company," I replied, trying to be helpful. "He's on Medicare now." "I know that," the secretary insisted. "We still need the information so that we can authorize his admission before we deny his benefits." Too tired to engage in unnecessary dialogue or to try to understand the peculiar logic of the insurance industry, I decided to simply cooperate and tell the secretary about my 60-year-old patient. "Ray has chronic obstructive pulmonary disease," I began, "as well as an advanced, inoperable narrowing of the trachea. He breathes through a plastic tube in his throat, but infected secretions are starting to fill the tube. He's on home oxygen, but he had a very difficult time breathing last night. This morning, he was weak, dehydrated, and febrile. His white count was 17,000. "Couldn't he be managed at home?" the secretary inquired. "I don't think you get the picture," I replied with uncharacteristic patience. "Once upon a time, this man was accidentally thrown forward in a truck cab, and a gear shift went into his throat, crushing his trachea. Since that time, numerous surgical procedures have left him with a throat full of scar tissue. His last surgical procedure was experimental, and a small plastic tube is this man's only remaining airway. I have been taking care of him for the past 12 years, and I have developed a pretty healthy understanding of when I can treat him at home and when I have to admit him to the hospital." "Does he have any other medical problems?" the secretary asked. "A few," I replied, as I prepared to recite a litany of his active medical problems. "For starters, he has coronary vascular disease, congestive heart failure, hypertension, diabetes mellitus, peptic ulcer disease, cholelithiasis, herniated cervical discs, herniated lumbosacral discs, assorted radiculopathies, crippling osteoarthritis, symptomatic benign prostatic hypertrophy." "I see," the secretary interrupted. "All right, we can approve him for 3 days. Don't you want to hear the rest of his diagnosis?" I asked. "I haven't even gotten to the good stuff yet." "No, that will be fine. Thank you, doctor," the secretary replied, quickly hanging up the phone. Comforted by the fact that Ray's hospitalization was being approved for 3 days by a company that no longer insured him, I went about my usual business of giving Ray the best possible medical care. I also went about my usual business of refusing to allow the directives of health insurers interfere with the care of my patients. For the first few days of his hospitalization, Ray appeared to be improving, but then the inevitable finally happened. Following years of suffering, the cumulative effects of multiple incapacitating illnesses, Ray's heart could no longer take the strain. Following Ray's death, I spent the entire morning at the hospital comforting his wife, the majority of his 10 children and 22 grandchildren, and few close friends. A few days later, I delivered the eulogy at Ray's funeral. While preparing Ray's eulogy, I relived many of the experiences we had shared in our 12-year association. Although I tried to concentrate on our happier moments together, I couldn't help but think about some of the suboptimal experiences we had also shared. I couldn't help but think about our many fights with hospital billing departments, insurance companies, workmen's compensation, the Disability Bureau, and Medicare. Ray's insurance coverage was constantly being punted from one insurance company or federal agency to another, and the incessant phone calls and letters from his insurers discouraged Ray and made him feel like a burden. I couldn't help but think about how laymen were always trying to dictate the length of Ray's hospital stays and how no one ever seemed to understand the nature of his problems. A peer review organization even gave me a tough time once for treating Ray with intravenous hydrocortisone for a week and not placing him on oral prednisone at the time of discharge. The reviewer didn't seem to care that Ray didn't need prednisone as an outpatient or that he had many contraindications to the chronic use of the drug. The reviewer seemed more concerned about keeping Ray out of the hospital, and he seemed to think that this could be achieved by placing Ray on chronic steroid therapy. I couldn't help but think about the sacrifices Ray had to make just to be able to afford many of his medications. Ray lived just above the poverty line and didn't qualify for drug assistance. On one occasion, Ray was told by another physician that his doctor should learn about the sustained release theophylline preparations. Ray, who had long profited from aminophylline, which he took 4 times daily, didn't know how to tell the other physician that he couldn't afford the expensive sustained release capsules. He also didn't know how to tell the other physician that his doctor routinely bought his aminophylline and a number of other medications from a wholesale drug company without any charge to Ray and without any reimbursement from his insurers. Ray didn't know how to explain many things to many people who were only temporarily or peripherally involved in his complicated health care, so he swallowed his pride and generally offered very few explanations at all. I couldn't help but think about the difficulty Ray had each time he was sent to a major referral center. Ray was just an extraordinarily ill human being who only wanted the medical or surgical care he couldn't receive at a small rural hospital, but more often than not, he was seen as a malpractice suit waiting for a place to happen. On one occasion, a compassionate ear, nose, and throat specialist agreed to perform experimental surgery on Ray with the hope of reconstructing his diseased airway and sustaining his life. Feeling threatened by a potential malpractice suit, the ENT partner refused to assist in the surgery. To make matters worse, the partner, who wanted nothing to do with the case, even refused to order badly needed medications for Ray post-operatively. Ray suffered an entire weekend in a hospital bed because of an arrogant physician's misconceptions. Thinking about all of our experiences together made me realize that I had walked with Ray down many different roads. It also made me realize that caring for Ray had forced me to take a closer look at many of the things that were wrong with our healthcare delivery system. Following Ray's funeral, each member of his family came up to me and thanked me for caring for their father. Their embraces, tears, and kind words were as sincere as any I have ever known. "Thank you, Bernie," one of Ray's daughters said, hugging me. "We never would have had him this long without your help." In the many years that I labored to preserve Ray's life, I became well aware of everything that was wrong with the practice of medicine. It took Ray's death to remind me of everything that was still right with it.
Allie's a 4th-year medical student at Temple University right now, and this time next year she'll be a doc, and she's going to go into pediatrics, which I told her is just like geriatrics, except it's different. People are smaller. Okay, so medicine from the heart. Well, first thing you got to do to practice medicine from the heart is listen to what your patients are telling you that they need. And I'm going to go through just a bunch of things that you might think about, and probably you're aware of most of them. Some of them might be new to you, but it'll perhaps just reinforce your own beliefs. And the first thing that patients are looking for is for us to join AAA. Not the American Automobile Association, but that society of healthcare professionals that realizes that the key elements to success as a healthcare provider are ability, affability, and availability. Ability, that speaks for itself. Our patients want us to be good, and they don't only want us to be able to handle the usual stuff, they want us to know about the side effects and the complications, and they want us to be there for them. Affability. The worst thing that can happen to a sick patient is a healthcare provider with an attitude. You know, if we can all go ahead, if we get our whole profession to go ahead and convince these people that it really matters to us if they live or die, and it really matters to us that they're well, they melt in the palm of your hand. It's that simple. Availability. This gets a little bit trickier. They define a specialist as someone who trains his patients to get sick only during office hours. And, you know, unfortunately, that's what's happened to a lot of healthcare. A lot of primary care physicians are unavailable to their patients. And they go through all kind of nonsense that the patients won't utilize. They go through services, and they go through machines on the telephone and everything. And you know from your experience with patients, especially elderly, that they get worried about stuff. And sometimes all they need is a calming word from somebody who they trust to let them know that it's okay. Now, there are a lot of ways to work this, and it's not practical for everybody, but I'll tell you how I've been handling it for a quarter century. I give everybody my phone number, my home phone number. It's my home and office number. It's there 24/7, and when you need me, I'm there. It's as simple as that. Because it's a lot easier for me to handle something over the phone in a couple minutes and stop a potential difficult situation from happening than it is to be confronted with a difficult situation. And you know, even when you do get that phone call, you have no obligation to say, well, we'll go and open up the office for you to come down right now. Your only obligation might be, you know, I don't really think that the chest pain can wait till tomorrow morning. Maybe what you should do, why don't you go over to the emergency room now and let them just check you out to make sure. That might be your only responsibility. But yet, you're the doctor, you're the healthcare provider, you're the nurse, you're the person making the decision, and they trust you. An important point to understand is whenever a healthcare provider relinquishes control of a patient, you're inviting a malpractice suit. Patient goes to an emergency room, well, you know, didn't your doctor know you had this? Didn't you? And not knowing what you've done, not knowing your awareness of the patient's problems, and maybe since you saw the patient last, they've started to develop an entirely different problem. So believe me, being able to be the one to handle the problem, it's diamonds for your patients, and it's really a safest way to practice medicine for you. And most patients don't abuse it. When they know that you're there, yeah, the first couple times they'll try you out. They'll call you at nighttime or on a weekend. Once they find out that you mean it and that you're really there, they usually respect your needs too. Now, patients want to live, and too much of healthcare is always telling people that, well, these are the things you can't do, or these are your disabilities. Patients don't want to hear that. They want to be able to live. They want to know the things they can do. They want to know about their abilities. And we can help them. Let me tell you a quick story. I had a nurse, mid-50s, a patient who was a nurse in her mid-50s. She was going to a gynecologist at a rather large hospital for quite a number of years, and then he finally decided to take out what he thought was her fibroid. And it turns out, when they opened her up, they had to close her right back up because she was filled with ovarian cancer. So they took a few samples for biopsy. They tried her on chemotherapy. She had an anaphylactic reaction to the chemotherapy, almost died. And after prolonged hospitalization, the gynecologist came in, threw up his hands and said, there's nothing more we can do for you. You know, go home, contact your primary care physician, see if you can control your pain. That's all we can offer you. And as the doctor walked out the door was still open. He had a whole entourage of residents and medical students. Somebody said to him, how long does she have? And he says, she'll be lucky if she has 2 months. So they went home, and to make a very long story short, her husband was very upset, didn't know how he was going to be able to take care of her. They called me. I said, don't worry about this. I'll take care of her in her home. That's not a problem. I'll come and take care of her there. So we started managing the little problems. We got her pain taken care of with some Duragesic patches. We took care of some other problems. We got home health nursing to come in. And this woman had an extraordinary will to live, and there was always something on the horizon that she wanted to live to be able to see. The first thing was her son's wedding. She wanted to be able to get well enough so that she could go to her son's wedding and have a piece of wedding cake. And so we kept encouraging her in that direction, and she did. And other things happened after that, and we kept encouraging her, and she did. And every time there was a small problem, a lot of times over the phone, we handled it. And believe this or not, she died 3.5 years later on a camping trip in Canada. Patients want to live. Let's help them do that. What do patients want? They want us to communicate better. We have a major problem as a profession in communications. I mean, a lot of healthcare professionals just don't get a clue that they're not getting through. Could be because of the fact that the only thing that they think they can do as a healthcare professional is use big words that patients don't understand, or they don't take the time that's necessary to communicate. Sometimes there are actually elocution problems where people just don't understand the person who's giving them instructions, either through an accent or through some other type of problem. I mean, I'd hate to come here as somebody from a foreign country and try to go through the United States and understand what we were all talking about. You know, it's like the movie Honky Tonk Man, where Clint Eastwood goes and wants to find out where the bus leaves from. The guy says, in Arkansas, right here. He goes, where's right here? Right here. So I think it'd be kind of funny to come here and thinking that you knew English and then go down south, go to Boston. I love it when I go down south and I'm in need of something really bad in a convenience store, and I stop, and I always have this smiling girl behind the counter. I said, do you have this? And she goes, we sure don't. I love it. We need to learn how to communicate. Let me tell you another quick story. I had patients in their 80s. They were snowbirds. They went to Florida every winter. They came back after one winter, and the wife called me. She says, could you see my husband next week? I said, why? What's the problem? She said, he had a problem right before we left Florida. He felt like he was going to pass out, so we had to take him to an urgent care center, and a doctor saw him, and he did a cardiogram and a big long strip, and he told him that we had to see a cardiologist. So we drove home. It took us 3 days to drive home, and, you know, we thought we'd call you and make an appointment for next week. Well, I said, what did he say about his heart rate? Well, it was very low, he said. Well, could you take his pulse right now? Yeah, take it. Comes back a minute later. It's 20. I said, it's what? It's 20. Bring him right over. So she came over, and the doctor at this clinic did the perfect stuff. He did a long rhythm strip which showed a complete heart block. But it was never communicated to this guy, you need a cardiologist now. They just didn't understand what this guy was saying. So they took it to mean, well, when you get home, find the cardiologist. The man drove through traffic on Route 95 for 3 days to get to upstate Pennsylvania. Now, nothing was done wrong by the physician. He did everything appropriately to diagnose this man, but he didn't communicate the most important thing, that you got to get a pacemaker quick. And by the way, within 1 hour of him coming to see me, he was already admitted in Binghamton and getting scheduled for an emergency pacemaker insertion. But could you imagine if this guy passed out going through Jacksonville on one of those interstates and a big crack up? Could you imagine the lawsuit that would have eventuated from that? So we need to know how to communicate better. Part of the communication, we need to know how to educate. Our patients want to be educated. They hear the word heart failure. They think it means that their heart's going to stop. They don't know that they got fluid on their lungs and that a pill will make it go away. They hear the word heart block, and they picture their arteries all clogged up and like they're going to need open heart surgery. They don't understand what it means. You know, and heaven forbid, you ever show them an ER chart where written on the top is SOB. Boy, you got to know how to communicate. Madam, honestly, this is not you. This is your symptom. So we need to educate as well. You know, we work in a world where we have to prescribe drugs, and that's a major problem because we use drugs with not an awful lot of rationale. You know, a patient goes to see a specialist, and she might have just gotten a supply of 100 of some type of beta blocker, maybe a atenolol or metoprolol. And the first thing that somebody wants to do is change it to another metolol. So she goes ahead and she's got 99 pills on the shelf, which are going to stay there forever, which she had to pay for, because she's going to get another beta blocker within the same class, which probably isn't going to offer her more benefit. So we got to learn how to be a little bit more considerate, maybe use up the other supply first. I mean, obviously, if somebody's on Coumadin and they're bleeding, you got to stop the drug. So there are obviously times that you have to stop a drug, but there are a lot of times that you really don't have to just throw pills down the drain. Another thing, too, is a lot of our patients can't afford drugs. They just can't afford it no matter what they do, and it's a big hardship in their lives. And I got to tell you about a program called the Medicine Program. I don't know if you've ever heard about it, but it's an extraordinary thing that you need to look into. Just go onto the internet and put into your server the Medicine Program, or www.themedicineprogram.com. This is a clearinghouse for all of the drug companies, and every drug company has a patient assistance program, but they don't tell you about it, because why would they want to give you $100 worth of pills free if they could sell you $100? So it's not well known, but they do exist. And what this place does, the Medicine Program, they have the patient fill out a sheet. And like if the patient needs 5 medications, if they're on Prevacid, Vasotec, low pressor, Zoloft, and Indocin SR. What they do is you fill it out, and they only deal with proprietary medications, not generics. You pay them $5, once in a lifetime fee, $5 per medication that you want them to get you. They then go through all the houses and they arrange for you to get lifetime supplies of free medication, and the program works. I've written extensively about it in the two books of essays I've written, Medicine from the Heart and Medicine Between the Lines. I'm not associated with it, but I'm telling you, the thing works, and I have saved hardships for patients that were paying like $700, $800 out of their pockets to stay alive, patients that have had like 5 heart attacks and were diabetic and had other problems. So a way that we can really help these people is to get them involved in the medicine program. I'm telling you, it works. It really does. Now, big thing that patients need us to do is to recognize their belief in God, to recognize their faith. We don't have to believe in God. We don't have to have faith. It has nothing to do with our personal beliefs, but it has to do with a very simple premise. The majority of our patients are people who believe in God, and they believe that God heals and that God works miracles and does all these things. They pray to God for their health. So we would be foolish as healthcare providers, regardless of our own beliefs, not to use that to our benefit. And it's been shown conclusively that people who believe in God do extraordinarily better with their health care. In 7 of 8 cancer studies, people who went to church regularly did better than people who didn't. Same thing happened in 4 of 5 blood pressure studies, 4 of 6 heart studies, 4 of 5 studies of general health. And it happened regardless if they were young patients or old patients, regardless if the problems were acute or chronic, regardless if the patient was a European Catholic, a Japanese Buddhist, or an Israeli Jew. Regardless, their belief in God was very helpful. Now, medicine got involved and they said, okay, well, how can we explain this? There must be an explanation. Well, the first thing was, well, if you're in organized medicine, you have a big social support group, and that helps people do better. That's an explanation. Another one was, well, if you're in organized medicine, you're usually more disciplined. So that helps you cope better with illness and suffering and pain and stuff like that. Then there was the one that got a little bit more scientific and said the actual act of praying reduces blood pressure, it reduces heart rate, metabolic rate, respiratory rate, it forms a relaxation response, and it reduces stress. So there have been all kinds of explanations. Now, I got my own explanation, which has never been published anywhere. I think there's a God. That's just me, though. I think there's a God who listens to prayers and works miracles and heals, and I've seen miracles in my practice, I really have, so that's just me. But the point is, patients really appreciate it if you think they're on their side and that you respect when them coming in saying, well, you know, my family's making a novena for me, or my family's going to Mass for me. And when you see patients, you don't have to get really involved in the religion like every time they come in saying the rosary with them. It's nothing that prolonged. You know, I have a patient come in that I know is going through a tough time. I had one this morning where I had a follow-up on a patient who I saw yesterday, and I had to tell her that she had metastatic lung cancer. I called her this morning, and I said, hey, and I said, I want you to know I'm praying for you. And you know, that's what I do in the office. Somebody who I know is very religious, when they're walking out, if I know that they're in a crisis, I say, hey, just know that I'm praying for you. And as they're walking out the door, I fulfill my part of the bargain. I look up and I say, dear God, this person's going through a lot, just help them. That's prayer. That's all you got to do. So they want that, and they need it. And most of our patients really are from a religious background. So it's to our benefit to at least start to understand where that's coming from. Another thing our patients don't want us to be doing, or they do want us to be doing, is start getting on the same page together. You know, we talked about AAA. Well, there's a AA, Alcoholics Anonymous. And I took care of an alcoholic a lot of years ago, and I learned a big lesson from this guy. I said, did you ever learn anything going to AA meetings? He said, yes. He said, I learned that there are a lot of things that you need to learn in life that you never thought about. And I said, like what? And he said, well, the most important is the unspoken word need never be regretted. Or one need never regret the unspoken, unkind word. And I thought about that, and I thought, boy, that makes an awful lot of sense. You know, you can think something about somebody who you don't particularly care about, but you have to watch when you say it. And you know what we do in this profession, which really is terrible? There's too many healthcare professionals saying nasty things about other healthcare professionals in front of patients. It's not the place to do it. When a patient's lying in bed thinking that they're dying, they don't need to hear from somebody, "We're not really sure that your doctor knows what he's doing." Happened to my patient, happened to a patient who was up in one of the hospitals here recently. Now, you know why it doesn't work like that? It doesn't work because the person who says that is the person who actually winds up being doubted by the patient. You know the old Polish saying, you point a finger at somebody, you got three pointing at yourself? Bottom line is there are mechanisms. If you really believe somebody to be incompetent or possibly injurious to someone, there are all kind of mechanisms to follow. Nurses can go to a nursing director. Physicians have medical staffs. That's where you handle these problems. You don't go in front of a patient and say, and the same thing in an ER. ERs are notorious. "Oh yeah, well, your doctor didn't know that you did this or had this or whatever." And then the patients there are in the middle of everything and they don't know what's going on. So we have to watch the way we talk to people and what we say. One need never regret the unkind word left unspoken. Now, patients will teach us that home is where the heart is, or there's no place like home. What they want us to do is to use their home as much as possible. There are a lot of people that could be managed at home if they had our help, bringing in home health nursing, home health physical therapy, homemaker services. Not everybody in the world needs a nursing home. And the other thing, too, is there are a lot of patients that we could be treating at home that don't need to be hospitalized, where a lot of them don't do that well. They have a tough time. And I've been doing house calls for a quarter century, and they do not have to be the type of, let's have a cup of tea and let me show you the family album for the next 3 days. Once you establish a rapport with your patients, you can get in and out and you can say, "Hey, look, boy, what a day, man, am I behind. Got to go and I got to do all this stuff, but I want to take care of you now. What's going on today?" And you sit down with them for 2 minutes, you let them tell you what's going on, you take care of them, and you're skating. It's as simple as that. So it doesn't have to be a prolonged type of intervention, but it's extraordinarily valuable. Now with home health nursing, we treat pneumonias at home with IVs. We do all kind of interesting stuff. And they do better, and they respond faster than when they're in the hospital, in my own estimation. I feel somewhat qualified to say that because 25 years ago, I averaged about 350 admissions a year to the hospital. This year, if I put 5 people in, this could be a lot. So I've really had a dramatic metamorphosis in my own practice, seeing how I could do things more effectively. Patients have a lot of other needs. They want us to be able to involve a lot of people when necessary. They want us to be able to make sure that their children know what's going on when they're elderly patients. Some of them don't. Some of them have rifts with their kids, and that makes it kind of difficult. But there are times when you have a situation where their health is starting to fail, where it makes a lot of sense to go ahead and at least let people in their family know that the parents might not be telling them everything that's going on. And, you don't have to initiate any of this. An easy thing to do is to say to one of your patients, "I've never had the chance to talk to your son or your daughter. Why don't you have them give me a call sometime? Here's my number. I just want to talk to them for 5 minutes and just make sure they know all the things that are going on with you." And that's a really smart thing to do. Not only do you engender a tremendous amount of goodwill with that entire family, but you ward off a lot of problems that you have nothing to do with. Probably everybody here has experienced something like a patient comes in, is in an accident, they're in their 80s, they're in a car accident, now they're on a respirator, and nobody seems to know what to do with these patients. Do we pull the plug? Do we continue? Does their family know? And a lot of times, they might have a son or a daughter who lives in California who they haven't seen in 10 years. And when you have to call these people in a crisis situation, it's a different thing than when they're calling you electively. Because, sometimes you get stuff like, "How did you let them get like that? How did you let them get that bad?" What? Why weren't we notified of the fact that they were getting so bad? Well, why? I don't know. Didn't you ever talk to your mother or father? They haven't seen them in 10 years, and now they're going to blame you for the guilt they're feeling for not having seen them and now being confronted with the situation. Or the one I really love, and I've had this happen a couple times. Well, we're in San Francisco in a suburb, and, yes, we should get out there. I got 2 important house showings tomorrow. Takes a half hour to get to the airport, We may be able to get out of here by Thursday. Would you please do everything you can, and you do everything you can for them, and please keep them alive till we get there, because there are things we want to say. And you go. And I've had calls just like that, and I'm not trying to be maudlin, I'm not trying to be sarcastic. So our patients want us to involve as many people as we can when necessary. Our patients want us to listen to them, and what they want us to do is take the time to listen. We have to open up more time in our schedules. We got to slow down these assembly lines we got. Got to slow them down, and we have to be able to go ahead and be able to have the time to listen to what people say. And if they have a problem where we don't have the time, we have to arrange a mechanism where they can get in touch with us at a different time so that they have the opportunity to tell us what they need to tell us. They want us to be knowledgeable. You know, it's what an indictment on our profession that all our patients learn everything about medicine from CNN. I mean, and the questions that come with, I have to excuse myself and say, wait a second, I hear the phone ring. I have to go turn on CNN, find out what they're talking about because I haven't watched TV that day. But you know, you have to go ahead and now with the internet, there's no excuse to be able to look up some of these things. And usually it's not even medical stuff. Yeah, you get the stuff like, well, are these arthritis pills really that bad for you? You know, or do I really need these cholesterol pills? And you know, so you have a lot of things that you have to answer like that. But there are other things. You know, they come to you, you know, what about the Harvard medical practice study? What do you think about that? Or what about the Institute of Medicine where all these people are dying because of medical care? You see, the message they get from TV isn't the message that we would give them. So we need to be knowledgeable enough to sit and discuss these things with them. We got to learn how to talk to people about our mistakes. And we don't make too many mistakes. But you know what we have to do is develop a mechanism so that when people think we've made a mistake, we have to know how to talk to them intelligently about it. And we have to be willing to do that. A number of the essays that I've written in my books have been republished either in medical journals or in magazines and newspapers. And Medical Economics recently did one that I wrote called Talking About Our Mistakes. And it pointed out the necessity of being able to sit down with patients frankly and discuss the difference between maloccurrence, which is something that nobody really wanted to happen, but it was just an adverse effect of something, versus malpractice. So you could have a situation where a patient has pneumonia, you put them on Levaquin, you cure the pneumonia, 2 weeks later they have terrible diarrhea. And they could come to you and they could be so sick, they might even have to be hospitalized for the diarrhea might get so bad. And they might say, well, you know, you got me really sick with this, you know, it's malpractice. You have to be able to say, hey, look, you had a complication of a treatment which you required, we diagnosed it appropriately, we've treated it appropriately. That's a maloccurrence that we've handled appropriately as compared to, well, you've been telling me about 2 weeks about diarrhea and I just said it'll go away or take some Pepto-Bismol, didn't do any kind of testing for it, and then they wind up getting dehydrated, hospitalized, they develop an electrolyte imbalance and have a cardiac arrest. Then somebody can say, you know, that's malpractice, and there's a difference. So we need to be frank about when things don't always go exactly the way we would like them to go, and that happens. What's in the name? You know, that's a question everybody always asks. What's in the name? Well, let me tell you something, a lot more than most healthcare providers realize. A lot of healthcare providers call people by what they think the patient wants to be called. And you know, like I did my residency at Abington Hospital outside of Philly, where all these corporate presidents and the owners of all the ball clubs down there, they all receive their care there. And I found it ironic that there'd be this very frail 80-some-year-old man who was a corporate giant. And he'd be afraid. It's the first time in his life he was in a hospital bed, and he'd be lying there. And some 18-year-old nursing student would come in and go, Tom, you wet the bed again, and now we got to change it all over again. And I'm thinking to myself, you know, this man's a corporate giant, and he's unable to go ahead and express what he really feels to people who he thinks he requires for his health care at this point. So, you know, you need to find out what makes them comfortable. A lot of people are afraid to tell you, you know, I sort of resent, I'm 90 years old and I sort of resent you calling me Molly. You know, my children call me mother and everybody else calls me Mrs. So-and-so. So the first thing to do, which I always do with people, is I say, what would you like me to call you? I always address somebody by the most appropriate title I can find, Mr., Mrs., Doctor, Colonel. I try to give them a great deal of respect. And then if they say to you, you know, my name's Joe, everybody's called me Joe for 90 years, I want you to call me Joe, then you have a reason to call them by their first name, but not until you've established that common ground. The other thing, too, is what I personally resent, is when somebody mispronounces your name, which can happen, and they're corrected, and they persist at mispronouncing your name. You know, what might be Jędrzejewski to somebody might be Jędrzejewski to the person. And that person might be of an ethnic heritage that takes a lot of pride in the way their names are pronounced. And they don't really have an awful lot of say in if you mispronounce it repeatedly, but they give you a whole different type of respect if you go out of your way to realize that a patient's name is their signature and pronouncing it correctly. What I do if I really am stumped with the name, I'll say, you know, did I mispronounce your name? How do you pronounce it? It's a beautiful name. I don't want to get it wrong. And they'll say it one time. I'll say, boy, that's beautiful. What ethnic derivation is it? And you've established a whole different working rapport by doing that. An unusual thing that happens in a lot of practices is that you run across a patient who things just aren't working with. And it's important, if you really want to practice medicine from the heart, to understand that you're going to have an occasional practice that you're just the wrong healthcare provider for. And it might not only be because they require something totally out of your league, you know. Oh, yeah, you wanted to kill yourself again last week? Well, you know, just take another Xanax or something. This is a patient clearly that needs the professional services of a psychiatrist. But even more so, somebody who's coming to you for primary health care, they might just be somebody who there's just a chemical imbalance between the two of you, and you know you're never going to be able to succeed. And what we need to do, what's really more humane, is working out mechanisms to sit down and frankly discuss the entire situation. That I think there may be other healthcare providers that can help you more than I am. And I can help you find one of these people, and you know, we'll do everything we need to convey your records to them, and you cooperate with something like that. But that's a part of the humanity of medicine. Realize when something is just outside of your sphere of being able to help. Another thing is that we need to learn how to protect our patients, especially elderly patients who, when they go into an institutionalized setting like a hospital, frequently get confused. This has always been one of my big interests, idiopathic confusion of hospitalized elderly patients. They go in crystal clear, 2 days later, they don't know who they are, they don't know where they're at, and nobody seems to know what to do about it. I had a situation a couple years ago, a gentleman about 60 years old, been a patient of mine for many years. I was out of town for a few days, and he fell and broke his hip, and he was sent to a big hospital. And the man was an ex-fighter, tough guy. And he went into the hospital, and they started, because he had a real bad hip fracture, they had to operate. They started hitting him with all type of narcotics, and he got very confused, very agitated, very combative. They had to restrain him. They had to hit him with Haldol, and it got to be that things got worse, and his other healthcare problems got worse, and it got to be, finally there was nothing left to do, and they just threw their hands up and said, you know, we don't know what else to do. So what happened was the social worker at that hospital called the social worker at my hospital. Nobody called me about it, but she says, we want to arrange a transfer to your SNF. And the social worker at my hospital naturally thought that I knew about it, so they started the ball rolling toward transferring him. When the family finally called me and told me about it, I started making some phone calls, and I said, I don't want him transferred to an SNF. And they said, well, why? I said, because I know him well enough, and with this acute thing, the whole reason is this man has been a fighter his whole life. He's tough. He goes into the first threatening situation in his life, and he decompensates mentally. And I said, I'll tell you right now, we put him in another institutional setting. We may never get him back mentally. He may be confused for the rest of his life. I said, what I want you to do is this. I want you to take him home, and I want you to call me when he gets there, because I will come out the next day and make an immediate house call, start taking care of him. And I said, you're going to curse me that night because he's going to be confused, he's not going to know anything, but I want you to keep throwing at him all of the sons and daughters, all the grandchildren. I want you to let him sleep in his own bed. I want you to let him taste his own coffee. I want you to do all these things, and let's see if I'm right or I'm wrong. If I'm right, I saved his life. If I'm wrong, the hospital's 5 minutes away. I'll admit that I'm wrong tomorrow, and we can put him in the hospital. So they agreed to do that, and they took him home. The next morning, he lived on a little hill, and the next morning I parked my car, I'm walking up the hill, and his son started walking down the hill with me. And his son always had a weird affect. I didn't know if the guy wanted to start a fight or what. And he said, you go in there and see what's happening. And that's all he said, like one of these cryptic type things. So, you know, I'm imagining all kind of things. You know, like the electric is now rewired into the plumbing. You know, you turn the TV on and the water level goes and the toilet's flush. I didn't know what was going on. So I walk in, and here's my patient sitting at the table drinking coffee with his brother, and he said, well, what are you doing here, Doc? I said, you okay? Yeah, sit down and have a cup of coffee. Hey, maybe you can explain, because nobody around here seems to know. When I fell and broke my hip, what happened? And never was confused the day after that. They said that he went home that night, and they were going to call the hospital at least a dozen times that they were bringing him over because they thought this was as much as they could tolerate. He went home, he got some people around him that he knew, he reset his thermostat. We saved his life by sending him home instead into an SNF. Now, You know, they talk about, in all the journals today, about the effect, again, of managed care on people not being able to go ahead and give pro bono care. You see all these kind of things, how all of our health systems today have interfered with our ability to be charitable. I don't believe it. I think we need to be more charitable until we can sort things out in this healthcare system. And I think that nobody doesn't have the time to fit one poor person into their life every day and really make a big difference. And we can do that, and we all have the ability to do it, or the ability to go ahead and rip up some charge slips and things like that. You know, I guess we all have a little bit of a Cisco Kid or Robin Hood in us, and I think sometimes we have to think about doing that. Patients want respect, you know, and they want respect if they're the richest patient in the room or the poorest. We got to learn how to even it out. We got to learn how to make the same kind of fuss for the millionaires that come into the office to the people that are on welfare, and make them understand that we respect them and that we respect their privacy, and that they're not going to go down to McDonald's and hear about their latest examination and what everything showed. We got to go ahead and we got to show a lot of respect. Sharing. People want us to share ourselves with them. It's important. I shared my daughter with you today. I'm going to share with you a couple other facts. I'm going to share with you the fact that her older brother, my oldest son, is a doctor. He's in the second year of his medical residency at Temple Hospital. I'm going to also share with you that the other guy at the other end here is my youngest son, who starts medical school at Temple this fall. And I'll be happy. I'll be standing at the end of the door to collect charitable donations on $35,000 a pop, and not even a free lunch. So if you'd like to contribute. And they say, you know, why does he write? Why? Because I accept Medicare. That's why I have to write. So I have 3 kids going to be doctors, and I'll tell you who's responsible. And there's another lady sitting in the front row there, happens to be my wife of 31 years, which has guaranteed her immediate sainthood. And she's the one who, when these kids were small, encouraged them to learn. And so, you know, what did I just do? I did something from my heart with you guys. I went ahead and I shared. You know, there are a lot of things you could share with your patients. They want to know you. They want to feel like they're your friend and you're their friend. You know, they want to know what baseball team you're following this year, and they want to know, you know, what kind of music you like. So we got to take a couple minutes here and there to share ourselves with our patients. It's important. We got to learn how to preserve the time of our patients a lot better too. Maybe somebody here can tell me, what is the ego enhancement that a physician gains or a healthcare provider gains by having people wait to see him 4 hours every day? Did I miss something? Was I like going to the bathroom during that lecture in medical school? Or I don't get it. You know, again, we got to slow down the entire assembly line. We got to make time for emergencies too. When a patient's our patient, you know, they don't want to go to emergency rooms. You got to fit into your busy day a little space here and there that if you have somebody that you need to go ahead and do something about, you can do it then. We got to respect time. We got to be understanding. You know, we know all the protocols. We know the next step for the patient with chest pain. But, you know, sometimes these 90-year-old patients, they just say, you know, you've done so much for me. I don't want to go through this. I don't want a catheterization because I'd never go through heart surgery. You know, can't you just give me medication? And, you know, my husband's dead 10 years, and I'm going to see him again when I die, and I'm ready for it, you know. So we got to be understanding. We got to be understanding of their needs. Our patients want us to get involved. They want us to be vocal when there are things going on that are wrong within our profession. They want us to do things like, you know, write letters to the editor and get involved in different causes. They want us to be a part of the solution, not the problem. And that's something that we could all do a lot more of. I'll tell you, the easiest place in the world to get published and to have on your curriculum vitae that you wrote something somewhere, you write a letter to the editor to a medical or a nursing journal. You write it about something that they just published. You're going to have a fairly easy time getting published. And it's a great thing to show that you're involved. Another thing is we do a lot of testing with patients. And I got just the comments. You know, we got to practice some defensive medicine. You know, nobody invented the rules, but, you know, we're practicing a lot too much of it, like $2 billion a year, something like that. But that notwithstanding, we need to test and do routine things. This woman I told you about that I had a call today with the metastatic cancer, routine chest x-ray, asymptomatic. She gets routine chest x-rays a couple times a year. Asymptomatic, it came up. So the thing is, we have to do testing, but you know the one gripe that I have, what I see too many healthcare providers do? Patients sitting on pins and needles for 2 months until they see their healthcare provider. They're waiting to get the results of the test. And all the while they're worrying, Well, he didn't call me because I got cancer. Well, he didn't call me because it's inoperable. He didn't call me because I'm dying. You know, and you're looking, and right on your desk is a CAT scan, normal CAT scan. You know they're fine. You want to earn points with your patients. You get somebody to dial their phone number, and you pick up the phone yourself. Hey, I was just thinking about you. Hey, I want to call you. You know, I got great news for you. Your test is negative. Hey, look, I don't have a lot of time to talk. Boy, they're breaking down the windows here to get in here today. I got to run, but look, I just wanted to share the good news with you. Everything's negative. You're going to be fine, and we'll talk about it when I see you next month. You're not only a hero to them, but you're a friend, and that's what they need. Another thing, they want us to be ourselves. Believe me, what these people, these 90-year-old patients don't need is for us to be, you know, last week's hero on Grey's Anatomy. They don't need it. They want us to be us because there's something inside of us that they saw that made it necessary for us to be their healthcare provider in the first part. So they don't want any errors. They just want us to be real people. They want us to be a friend and the healthcare provider that they could say, this is my friend first, and that's important to them. That's what we could do individually. What do we need to do as a whole group collectively? We need to unionize. Not just doctors and doctors, nurses and nurses. Could you imagine if we could unionize and get together all healthcare professionals, doctors, nurses, dentists, optometrists, podiatrists, chiropractors, technicians? Do you realize the enormous say we would have in what happens in healthcare in America? I'm not talking about going out on strikes. I'm not saying, well, you know, somebody's got appendicitis, that's tough luck because we're out on strike. I'm talking about sitting down with people and saying, no, that's the way you used to do it. You know, we have half of the country in our group that are saying we're not going to do this anymore. This is the way we're going to do it, and we're going to base it on our patients. So, you know, there are a lot of things that we could be doing. One of the things would be to bring about a type of healthcare system in this country that insures 100% of people and is user-friendly to all of us. So as a conclusion here, before I give you one final remark, I'm going to bring up another outstanding fourth-year medical student at Temple. He was educated around, he was brought up around the suburban Philadelphia area. He went to Wake Forest, where he was a member of some very interesting things, not the least of which was a student health initiative where they got to students who were involved with drugs and alcohol and smoking and tried to straighten their lives out. He's also the chairman of an intramural program there. So he's been very active, member of Phi Theta Kappa. I'd like to present to you Mark Nowitzki, who's going to read a very short essay on what we could be doing in healthcare. It's a lighthearted essay that if you write a book called The Malpractice Epidemic and send it to Congress, it goes on a shelf. In 500 words, you could say the same things and people will smile and maybe take heed. Mark Nowitzki.
I'll be reading an excerpt from Dr. Remakus' Medicine Between the Lines. Chapter's called Stimulating the Economy. I had another one of those crazy dreams again last night. I was spending my first day on the job as Surgeon General, and as I sat at my desk selecting a secretarial pool from a Victoria's Secret catalog, the president walked into my office. "Good morning, General," he said, as he glanced at the cover of my catalog. "You've been Surgeon General for almost 30 minutes now, and I'd like to know what you've done to earn your keep." "Well, sir," I replied without hesitation, "I answered the phone a few times, carefully studied this human resources manual I'm holding, and worked out an economic stimulus plan." "Run your plan by me," the president said. "Well, to stimulate the economy," I responded, "we have to encourage spending. To encourage spending, we have to create jobs, increase wages, and make goods and services more affordable." "And how do we do that?" the president inquired. "National health insurance," I replied. "National health insurance?" the president asked. "Sure," I answered. "We give every American comprehensive, tax-funded national health insurance. Without having to pay for their employees' health insurance or medical care through workmen's compensation programs, both large companies and small businesses will have the money to create more jobs and increase wages." "We do need more jobs," the president acknowledged. "But that's not all," I continued. "Insofar as the cost of employee health insurance contributes to the final price of any manufactured item or provided service, some of the savings brought to companies by national health insurance would be passed on to consumers in the form of less expensive goods and services. This would increase everyone's buying power and allow our industries to become more competitive in both domestic and international markets. Not having to pay for employees' health benefits would also allow many small businesses to keep their doors open. The president mumbled unequivocally. And furthermore, I continued, national health insurance would also stimulate the economy by bringing millions of uninsured Americans into doctors' offices and clinics. It would increase hospital revenues by finally paying hospitals for all the care they rendered to uninsured and indigent, and stop the tragic, unnecessary closing of American hospitals. It would allow the healthcare industry to identify and eliminate the costly and unnecessary duplication of services by government and private health insurers, workmen's compensation boards, and disability bureaus as well. It would even permit hospitals and clinics currently being run by Veterans Affairs and other government agencies to be open to the general public. Is that all? The president asked jokingly. No, sir, I replied. National health insurance would also lead to the elimination of medical liability premiums from automobile insurance, homeowners insurance, and business liability insurance, thereby making these private insurances much more affordable to Americans. It would also take much of the strain off of our court system by eliminating many of the personal injury lawsuits that follow fender benders, slips on icy sidewalks, and injuries in restaurants, stores, and other business establishments. After all, without medical bills to pay, most Americans would never consider initiating a personal injury lawsuit. We do have too many lawsuits in this country, the president agreed. Finally, I concluded, the institution of a well-constructed national health insurance program would help dramatically reduce the cost of health care in America. For starters, a national health insurance program would allow medical malpractice claims to be adjudicated through a federal arbitration process, thereby eliminating the need for physicians to obtain expensive malpractice insurance. By not having to pay exorbitant yearly malpractice insurance premiums, physicians could afford to charge less for their services and still earn more. By no longer being expected to defend frivolous malpractice suits in court, physicians could finally stop practicing so much defensive medicine and stop ordering unnecessary diagnostic tests and consultations. This alone would reduce the yearly cost of health care in America by billions of dollars. This kind of malpractice reform and healthcare reform would serve as a constant stimulus to the economy. Every American would finally have health insurance, and the taxes resulting from increased company profits, higher wages, and more jobs would help pay for it all. Good work, the president said, as he quietly confiscated my human resources manual. So what's next on your agenda? Trying to figure out why the Surgeon General wears a Navy uniform, I answered. As the president saluted and left the office, I suddenly awoke. I've got to stop eating Tex-Mex before going to bed. Thank you.
Mark is, again, going to be a medical doctor this time next year, and he's going to go into psychiatry, which I told him. I said, you know, psychiatrist is a doctor who studies medicine, which he doesn't practice, so he could practice psychology, which he hasn't studied. But, you know, I'll tell you, the future of healthcare in America, to me, seems awfully bright when I see not only my own kids, but I see the kind of people that are coming up through the ranks today and are going to be our future. We've got one last thing to do, and what that is, so that you could get your continuing education credits, is you got homework. Who said ooh? And the homework is like this. On your program today, it says that the objective of my talk today was to reveal the humanity still possible in modern medicine. So for your homework tonight, you have to go home, and before you go to bed, you have to look in the mirror. And in the mirror, you will see revealed the humanity still possible in modern medicine. Thank you.
I'd be happy to.
Now I know what Willie Nelson feels like. If you want to write, I'm going to give you an email address if for any reason you ever want to contact me. If you wanted to get any kind of information, if you wanted to get autographed copies of any of my books or anything, you can just get a hold of me for any reason, just with my name at Remakus, R-E-M-A-K-U-S, at epix, E-P-I-X.net, N-E-T. Remakus at epix.net. Oh, it's on there? Oh, I didn't know that. Okay. I'd be happy to answer any questions that you might have. Or if you want to get rolling with your final things here, I will remain after, and if anybody wants to come up to me and belittle me in person, that'll be all right. Any questions? If not, I'll talk to anybody individually. And thank you again very much.
Make sure you fill out your evaluation forms. Thank you all for coming. I hope you enjoyed it, and look forward to seeing some of you next year, maybe all of you. Thank you.